This is QD Clinic. Hi, I'm Jack Cush with Room Now. QD Clinic is brought to you by PSA All the Way. Look out for our Tuesday night rheumatology starting next Tuesday regarding PSA. We're going to do questions from Room Now Live. These questions come from mainly the hot topic session and also the rheumatoid arthritis session. What is your preferred drug for uveitis? Well, it's TNF inhibitors. The antibody-based TNF inhibitors are better than the receptor-based therapies. I think what you're asking is, do the other new drugs work here? And no, IL-17, IL-23 inhibitors are not indicated for uveitis. In fact, at least IL-17 may make it worse. There's some evidence of that. Next question, any special consideration for your patient who has hypermobility and systemic arthritis? I don't know what that means. Let's just take it apart. Systemic JIA, meaning Still's disease. Yeah, I have a bunch of Still's disease patients who actually have hypermobility, and it's called fibromyalgia with hypermobility, and they really don't have systemic JIA. Systemic arthritis, there really isn't an inflammatory systemic arthropathy associated with hypermobility. What is associated with hypermobility is, as you know, a lot of tendon and problems and muscular and periarticular pains, but no synovitis, no effusions, no true enthesitis. And a lot of these patients, in my opinion, actually they may have Ehlers-Danlos syndrome if you want to go that far. You want to see if they meet Baton's criteria for hypermobility, but a lot of them have fibromyalgia, and that should be sought for. Do we need to evaluate TMJ involvement in adult patients who get referred? We're talking about kids who had JIA who get referred to or get transferred or transitioned to the adult rheumatology clinic. Do we need to evaluate them for eye disease and TMJ disease? Eye disease, generally not. By the time they're adults, if they haven't developed uveitis, they certainly don't need to go as they did when they were kids and were being followed either every 6 months or every year by the ophthalmologist. TMJ disease is more common in JIA because of the problems with bone growth and having inflammatory disease. TMJ is not uncommon in kids, but and especially also in systemic JIAs as well as the polyarticulars. So if they have involvement, you should refer them. Again, I hate to keep harping back to fibromyalgia, but in my experience, a lot of patients with TMJ really just have fibromyalgia. Do you continue biologics like IL-1 indefinitely for SJIA and Still's disease in adults? Question for Dr. Hausman or Dr. Cush. And the answer is no. You don't continue it indefinitely. The vast majority of patients are going to have Still's disease. And this is in kids and adults for either 8 months to 8 years, and you don't know when. So you continue it until you get them into clinical remission, no fever, no rash, no serositis, no lymphadenopathy, no arthritis, and laboratory remission, meaning normalization of acute phase reactants and white count, and their anemia is gone. And when you have that for a year, then you're invited to slowly withdraw therapy. If they have active Still's disease, don't worry, it'll come back and remind you right away. With something very objective, not like I feel crappy or I'm not doing as well or I have more aches. No, it's going to be the return of fever, the return of rash, the white count, SED rate, and CRP are going to go up, and you're going to know that they need to continue to be on therapy. Right now, there is no good biologic or biomarker way of knowing that it's safe to stop therapy. But know that most people will go off therapy, especially IL-1 inhibition or IL-6 inhibition, if that's what you're using. RA patients who have burnt out disease but no obvious signs of inflammation, what do you do? What do you consider? Well, I think we talked about this in my session on refractory RA, and this is where the EULAR definition says in such patients where it's really hard to tell whether inflammation is going on, meaning it's hard to discern whether they have synovitis or effusions. They're certainly not going to have hot joints. Their SED rate and CRP may be unrevealing, as it is in more than half of patients with RA anyway. You may use ultrasound as your defining intervention here to know whether those patients may need further therapy or not. A question for Dr. Pope was, I have a patient with RA and fibromyalgia. I cycle through all the DMARDs, all the biologics, and a JAK. Patient does well for 6 to 12 months, then gets worsening pain. Would Vectra help? Would I try anakinra? Well, Vectra is not going to help you. I mean, for me, it doesn't qualify as a biomarker. The data that they lay out proves the past, not the future. It makes inferences that you can make from your own exam and other labs that you get. I wouldn't do a Vectra, and you could try anakinra, but if the patient has been refractory to all your best therapies for RA, don't you think it's the fibromyalgia that's screaming here? I would think about that. Do you believe that, IL-6 inhibitors have the longest retention rate in your practice? The answer is no. I think that the longest retention rate in practice still belongs to methotrexate. There are multiple studies showing that. And in fact, our biologics are not quite as good as we'd like to think they are. I mean, dropout rates on biologics over 4 to 5 years averages at more than 10% a year. And it's not really every year. It's a little front-loaded, more in the first and second year, less in the third and fourth and fifth year, but it averages out to about more than 10% per year. Recent study, actually, of psoriatic patients and looked at their biologic persistence over a 5-year period. 35% or less were still taking the same biologic 5 years later. So, again, most of our drugs, we do have to cycle them to maintain better disease control. And I think that may be biologically the smart thing to do. Rheumatoid arthritis especially is a disease that escapes control quite commonly. And maybe the thing to do is try to stay one step ahead of the devil by switching your MOAs in a programmed fashion. Those kind of studies have never been done. What type of screening do you do to assess for multimorbidity in your RA patients? And should you leave this to PCPs? No, you shouldn't leave the PCPs. You're the expert of RA. You know the implications here as far as multimorbidity, that it is more common, that it adds to poorer outcomes. You have to tackle multimorbidity. So if the patient isn't seeing the primary care as they are supposed to and are probably not, you should be doing, hemoglobin A1Cs. You should be doing, PSA and ordering, pap smears on patients in whom that's appropriate. You should be doing the screening things and or demanding it, requiring it for your continued involvement that they go to a primary care for those things. But I think you have to ask the question annually. Just like you annually should ask about influenza and vaccination, I think you might want to annually assess multimorbidity in patients. We talked earlier in the questions that were offered up about the routine use of a depression questionnaire in practice. That seems to make sense to me. Do you need to adjust methotrexate in patients with diabetes? The answer is no, absolutely not. You only dose adjust methotrexate because of renal insufficiency. You may dose adjust for better disease control, meaning patients not doing well. You go to oral split dosing or go to parenteral. What does that mean? Patients on 15 milligrams a week and they're not doing well. You could change that to 15 milligrams sub-Q or sub-Q, and they'll get 100% absorption, and likely that equates to delivering a better dose. Or you can keep it oral by going with 3 pills twice a day, once a week, let's say on Friday. By going to split dose oral at doses less than 15 milligrams, you're going to get closer to 100% absorption and do better. But worrying about toxicity and whatnot, you have to downward adjust in patients who are unreliable and patients who, and sometimes that's the elderly, but it really shouldn't be if you have good coaching and a scheme set up where the patients can safely take their medicine, but mainly renal insufficiency. Let's see. I have a patient who's carrying a diagnosis of long-haul COVID, meaning that they have prolonged symptoms due to COVID that occurred sometime in the past. Let's say it's more than 3 to 4 months ago. The patient continues to have severe fatigue, flu-like symptoms, and continues to have abnormal labs with an ANA and RF and CCP antibodies. The inflammation markers, however, are normal. As was discussed here in earlier questions, you can, after COVID, continue to have autoantibodies for more than 6 months. That doesn't necessarily equate to the other long-haul symptoms. More than 50% of patients with COVID will have these musculoskeletal and constitutional complaints for up to a year. Having those does not necessarily mean, along with the autoantibodies, does not mean that they're going to progress into lupus, RA, vasculitis, whatever. Again, you're going to have to make those diagnoses on grounds more than the laboratory tests alone, because those can be misleading in this situation. What do you think is most important in preventing RA? This was asked during the session with Karen Kostenbatter, and she answered to that was amongst the options of what could be done to lower the risk of getting RA in the future: smoking cessation, weight control, alcohol, vitamin D, and omega-3 fatty acid use. She said, hands down, it's smoking. But they're all important. They all can factor in there. 2 questions about turmeric. Does it have a role in preventing RA? No. Does turmeric have a role in treating arthralgias? Yes. It has, in many ways, COX-2-like effects. How long would you treat a patient with arthralgia with hydroxychloroquine if they were double positive, meaning RF and CCV positive? So you're talking about someone who has preclinical RA, and they're double positive, and you're concerned, and because arthralgists are using hydroxychloroquine, I wouldn't, but you're welcome to do so, but you don't have an endpoint. I think the conventional thinking right now on preclinical RA is the ones who have who are CCV positive, or those who are double positive, you watch more closely. They have a greater than 50% odds of developing RA. And then as soon as they get synovitis, then you step up with your best drug first, not your weakest drug first, your best drug first. If you want to treat with what you think is a mild drug for mild symptoms, you can do that, but there's no evidence for that. Wait a year and a half. We're going to see the data from the STOP RA trial. It's a very large, multiple thousands patients with these symptoms who are going to be randomized to either hydroxychloroquine or placebo, and we'll look at the outcomes. We'll know that in the next year or so. Last question: in patients with RA but not on JAK inhibitors, do you routinely screen for lipids? And if so, how often? I don't. But then again, if you're the rheumatologist managing their comorbidity, you should do that as part of comorbidity management. And the bottom line is that control of inflammation drives up lipid numbers. So if you have a very active RA and you check their lipids and they're normal, that may be falsely low because of inflammation. And then if you give them a TNF inhibitor or a JAK inhibitor or an IL-6 inhibitor, 2 drugs that we know, those last 2 we know drive up lipids, it's not surprising that the lipid levels will go up. And then if they're really elevated, then you might need to put them on a statin. But so far what we have seen is that, including the NTRAC trial, Actemra or tocilizumab versus etanercept, followed for 3 years. Yes, the IL-6 did drive up lipid levels in patients, and that was not associated with increased risk of cardiovascular events. So again, it's an artifact of inflammation control. That's it. Be sure to tune in next week for PSA All the Way.